Hello, everyone, and thank you for joining our webinar today. My name is Melissa, and I will be hosting the presentation today, and I'm happy to introduce Dr. Lisa Eyler. Dr. Eyler received her undergraduate degree from Duke University and her PhD in clinical psychology from the University of Pennsylvania. She completed a clinical psychology internship and a postdoctoral fellowship at UC San Diego and the San Diego VA. Since 1999, she has been on the faculty of the Desert Pacific Mental Illness Research Education and Clinical Center and is currently the co-director, and since 2004, on the faculty of the UCSD Department of Psychiatry. She participates on many committees, task forces, as well as being involved in research supported by several NIH grants. In this talk, Dr. Eyler will review evidence for altered brain aging in bipolar disorder and for changes in aging-related inflammatory pathways. She will present data from her own magnetic resonance imaging study of brain aging, which used multiple measures of brain structural and functional integrity to create a brain age prediction for each participant. She will also present initial results from her ongoing longitudinal study of inflammation, mood, and cognition in bipolar disorder. The implication of these findings for treatment and prognosis will be discussed. Welcome, Dr. Eyler.
Thank you so much, Melissa. Thank you for inviting me to speak today, and welcome to all of you listening. Thank you for being here on the day after July 4th, and hope to be able to give you some interesting and perhaps novel information about the idea of premature brain and biological aging and bipolar disorder. So this is the outline for my talk today. I'm going to start by reviewing some of the evidence for an increased prevalence of age-related illnesses and an earlier mortality in people with bipolar compared to the general population. Then I'll review others' work and my own work in terms of brain aging in bipolar, as well as biological and inflammatory aging. And then I'll conclude the talk by talking about what the implications of this work are in terms of how people should perhaps alter their lifestyle or work on treatments that consider bipolar disorder as a whole body disorder instead of just a brain disorder. So this idea that bipolar may be a whole body disorder has really been gaining some currency over the last few years, and part of the reason for this is because of the high rate of other conditions that go along with bipolar disorder at a higher rate in people with bipolar than those without. So for example, there's a 65% higher prevalence than in the general US population of obesity in people with bipolar. Similarly, hypertension has a 27% higher incidence, and this was shown in a general Danish population in people with bipolar. Metabolic syndrome, which is a cluster of features that increase risk for diabetes, there was 53% of people with bipolar met criteria compared to 27% in a study of the US population. And there was a slightly higher risk of diabetes itself in people with bipolar compared to those without in a veteran population in the US. So you can see that there's a higher risk of some of these disorders, which we typically think of as disorders of aging. As we get older, we get heavier, we have more cardiovascular risk factors, we have a tendency to get type 2 diabetes, and so what we're seeing is an increased rate of these age-related disorders. And unfortunately, this is also leading to a higher mortality in people with bipolar disorder. Now, it's probably not surprising that in this large study of deaths of bipolar patients in Sweden from 1973 to 1995, that there was a higher rate of death from things like suicide, accidents, homicide, than in the general population. So when you look at this table, you can see this is called a standardized mortality ratio, and it's sort of the percent higher, or the increased rate relative to the general population. So 3 times as much, 4 times as much, 15 times more deaths from suicide in men and 22 times more deaths from suicide in women with bipolar than in the general population, leading to a higher rate of these so-called unnatural causes of death. But you can also see from this table that there's an increased rate of a lot of different disorders that are so-called natural causes of death, including stroke, heart disease, GI problems, lung and respiratory distress, and disorders. So you can see that in those categories, there's also a 2 to 3 times higher rate of death from those disorders in bipolar disorder, leading to this increase in natural cause death as well. So it's not just suicide, but other factors that are leading to earlier mortality. And in a recent study, confirmed these findings from another Swedish sample that was published in 2013 and indicated that people with bipolar died 8.5 to 9 years earlier. And you may have noticed that, this very tragic death of Carrie Fisher, who was an actor with bipolar and also a vocal advocate for people with mental illness. She died very early at the age of 60 of a heart attack, and this led Scientific American to sort of put together some of the data that we were just talking about with this and ask the question, did her bipolar disorder contribute to her death? And I think the article comes down on the side of it's a very strong possibility that the heart disease that she had, or the heart problems that she had, as well as the sleep apnea that just came out recently, was just revealed, may have been part and parcel of bipolar disorder as a whole body disorder. So those of us that are doing research in this area are interested in whether there might be a different course of aging in people with mental illnesses, including bipolar disorder, compared to the general population. And this schematic shows some different patterns of aging. So in the black line, you see typical aging, where you kind of tootle along with however you're doing in terms physically, and then eventually start to decline and go down as your age gets older. It's possible that people with bipolar demonstrate a kind of premature aging, where at every age they are actually a little bit worse off in terms of normal age-related markers, and but that the rate of decline is similar. So it's kind of a parallel line to the black line. And then in the red, you can see that you could also have something called accelerated aging, where in addition to having an earlier start to some of these age-related disorders, you may also have a quicker drop-off or a more precipitous decline. And if this gray line, this gray dotted line of functional impairment, is the line by which if you pass it, then you'll have more difficulty caring for yourself, more hospitalizations, etc., then you can see that if there is either premature or accelerated aging, that line will be crossed at a much earlier age. The idea of progression adds the factor that perhaps the disorder itself is progressing. That is, it's getting worse with each subsequent episode, which may be contributing to this altered course of aging. So how do we try to disentangle these different possibilities or figure out what the implications are for premature, accelerated, and progressive course of aging? Well, it's made difficult by what I like to call the thorny triangle, in that we're looking at things at 3 different factors: how old somebody is, how long they've been alive, when their disorder started, and how long they've had their disorder. And of course, if you know any 2 of these, you also know the third. So it makes it difficult to disentangle the effects of these different things. But I'm going to talk about each of these, starting with duration of illness. So duration of illness is, of course, the number of years that you've been suffering from bipolar disorder, but there's also other factors that we like to call chronicity factors, which is kind of how severe has the disorder been across those years. How many mood episodes and mood swings have you had? How many psychotic episodes? Is there psychosis as part of the picture of your bipolar disorder? How many times have you been in and out of the hospital? These types of factors can lead to a more severe course or a more chronic course in some people than in others, even if they've had the diagnosis for the same amount of time. There's also what we would call chronicity-associated factors. So the longer that you've been having symptoms of bipolar disorder, it probably means the longer you've been on different medications for it. There may also be factors like increased risks for substance use and abuse, head injury, socioeconomic declines that may come from the symptoms of the disorder. So all of these can accumulate over the lifespan in association with the accumulation of more years having bipolar. And then, of course, there's the issue of age of onset. There may be gender differences. There may be some people who first have their symptoms very early, and some people who first have their symptoms later in life. And the typical versus early versus late, those age of onset, those folks may have qualitatively different pictures of the course of aging. So if you first start having bipolar disorder when you're already, say, in midlife, then your course of aging may be different from somebody who was already had symptoms from very early on. And then aging, you would think, would be the most straightforward of the factors. That is, how many years have you been alive? But people are recognizing in research on kind of normal or healthy aging that there's a lot of different factors that go into biological aging. So over those years, many things change, including you have more instability in your genetics, you have a loss of the covering that goes on the edge of your chromosomes. That's the caps that are called telomeres. Those can shorten as cells divide. There can be problems with the energy functions of your cells in terms of the mitochondria, and there can be issues with intracellular communication in the immune system and inflammation, which we'll talk about in a little while. So there's a lot that's going on when you're talking about aging, but mainly we just measure that to date, that's mainly just been measured by just looking at the number of years that people have been alive. So in order to distinguish between or to understand the processes of premature aging versus accelerated aging versus progression, there's different kinds of evidence that's needed. For premature aging, the idea is no matter how long you've been suffering from bipolar, somebody who has bipolar would look older than predicted by their chronological age. So somebody who was 45 years old in their measurements of, say, their brain function or their illness profile would look more like a 45-year-old would look more like a 60-year-old. Regardless of how long they'd had the disorder. Accelerated aging would be if you would then follow that person, that 45-year-old with bipolar over time, you would see that he or she might actually have more rapid drop-off in, say, cognitive functioning or brain integrity over time than people who didn't have bipolar. So that would show that there was not only premature aging, but also accelerated aging. It was a more rapid decline. And then progression would have the added thing that no matter how old you are, the worse your chronicity, the worse your brain, the older your brain or your physical functioning would seem. And that the more you accumulate episodes, the worse your abnormalities will get. And that this is true even after controlling for some of these chronicity-associated factors like the accumulation of medication burden, the accumulation of substance use, etc. So progression, I think, is one of the hardest things to really prove because it means that we have to really compare those with different paths and different chronicities at the same age and also see what happens over time in terms of the accumulation of episodes. So as I go through some of the evidence that others and myself have gathered in terms of the course of aging and bipolar, I want you to keep in mind this idea of premature, accelerated, and progression and see whether you think, which patterns you think fit the data as I'll be presenting them. And it may be that all of these things are not mutually exclusive, that you could have both premature and accelerated aging or premature and progression, or there may be different body systems that have different courses with aging, and so that's what we're still trying to figure out. So when we talk about brain aging in bipolar disorder, there's a lot of different measures that we can look at. And all of these measures are things that have been shown to change with age in people without mental illness. So for example, the size and the shape of different brain regions can be measured using MRI, and we can look to see whether there's thinning of the cortex, which is what we typically see with aging, and whether certain structures in the middle of the brain, like the hippocampus, important for forming new memories, might be shrinking, which is also seen in typical aging. White matter can become more abnormal looking. So on this slide, you can see some colored regions, some sort of speckles in the middle that are hyper intense relative to the rest of the white matter. And the white matter, again, is is showing the myelination of the connections between different brain regions. And these abnormalities get larger with age, typically. We can also look at resting blood flow, which is sort of the amount of blood that's being delivered to any part of the brain, and that's important because you need blood to be delivering the oxygen that the neurons need to work. And speaking of oxygen, we measure that with something called functional MRI. We measure the amount of oxygen change when people are doing tasks. So maybe when they're asked to remember and keep in mind numbers and then recall them later, or even emotional tasks where they're presented with faces of different emotions and asked to identify what kind of emotion they're looking at. And so we can use functional MRI to look at the response of the brain in terms of blood oxygenation. We can also look at white matter tract integrity. So again, looking at these long distance connections between different brain regions. And in this colored image, you can see different tracts that are colored different colors, showing the different connections between regions of the brain, and we can see how well those tracks are doing in terms of their structural integrity. And then kind of more functionally, we can look at how coordinated the signal is between one region of the brain and the other in terms of blood oxygenation. Just even at rest, it turns out that the brain kind of, different parts of the brain that work together normally when they're at rest and not doing anything particular kind of idle together, and we can measure that degree of resting coordination. So there's many different things that can show age-related changes in typical aging, and the question is, what does that look like in a younger set of individuals with bipolar disorder? Well, this study shows is one of the largest studies to date looking at the size of both subcortical and cortical regions. This is part of the ENIGMA consortium, which is a global group of investigators that are getting together and pooling their MRI data so that we can draw conclusions. And you can see here that in this study of subcortical regions, which are those regions kind of in the middle of the brain, that include things like, and I'm sorry, it might be hard to see this, the orange is the amygdala, this kind of teal, green, blue is the hippocampus, the pink is the thalamus, which is like the relay center of the brain, and then this darker pink is the ventricles. Those are the fluid-filled spaces in the brain. And interestingly, kind of as you get older, you have an increase in the fluid-filled spaces, you get a decrease in the size of your hippocampus, and so those two findings are very consistent, even though these are sort of typically aged, not particularly elderly bipolar individuals. They're already showing a smaller size of hippocampus and a larger ventricles compared to the 2,000 or so healthy individuals in the study. The same thing is true in the cortical regions. You get widespread thinning of the cortex in the bipolar group compared to those without bipolar, and that's shown with using these hot colors are showing thinner cortex in the bipolar group. And so you can see sort of widespread thinning across the cortex and some regions that are a little bit more affected in the front and back of the brain. So these are two very large studies suggesting that in typically aged, sort of normal age samples, as I said, not particularly elderly samples, you're seeing results that look very similar to older people without bipolar disorder. Here's an example of a study that was done in 2012 by Teague et al. And they found that for these white matter abnormalities, that individuals with bipolar 1 and psychosis had significantly larger volume of white matter abnormalities than healthy individuals. And they also found an interesting pattern of an increase from healthy to an unaffected family member to bipolar 2 to bipolar 1 without psychosis to bipolar 1 with psychosis, sort of a stair-step pattern here of increase in these abnormal white matter findings with the severity of the disorder. And they didn't look at age in this study. This was just sort of, again, a typical age sample, but you're seeing, particularly in the people with bipolar 1 with psychosis, quite a large volume of abnormalities that would be more similar to what we would see in an older adult without mental disorders. White matter tract integrity has also been shown to be altered. This is a study from 2013 by Norge et al. And this is a meta-analysis, which means that it's a study of studies. So they looked back at 11 different studies that all used what we call diffusion tensor imaging, which is what allows us to see those long distance tracks in the white matter. And they found that if you combine those study results all together, you find that there's a significant spot here in the right parietal occipital lobe where the red is showing that has less integrity across all these studies in people with bipolar compared to without. And loss of integrity of long distance connections is again an aging related phenotype. Now there have been some studies that have looked specifically at how age is related to gray matter in people with bipolar. This study found that there was a more negative correlation of total gray matter volume and age in bipolar than healthy comparison group. And basically what this is showing is that there's kind of a steeper slope with age in the bipolar group, saying that older people with bipolar had more loss of gray matter volume than older people in the healthy comparison group. This was a longitudinal study by Moorhead et al. That showed that over 4 years, so they followed the same patients and comparison subjects over 4 years and found that the people with bipolar disorder had more loss of their gray matter in areas of the cerebellum and also in the hippocampus and the fusiform gyrus compared to the healthy group, again showing perhaps an accelerated pattern of decline as you follow the same people over time. However, there was another study which was somewhat smaller and followed people for less time, didn't find any difference in the amount of loss of gray matter. And then I mentioned to you about the idea of progression and whether the chronicity of your bipolar disorder, for how long you had had it, made a difference. And then this study by Gildingers et al. In 2014 of 54 older adults with bipolar, they found that older adults had lower total gray matter volume than those without bipolar, but particularly among those with a longer duration of illness. So they found that there was not so much age-related changes here, but those that had to do with duration of illness. They also found that longer antipsychotic exposure was related to lower total gray matter, so a role for some of these chronicity-associated factors. And then that same study of 15 bipolar and 15 non-bipolar comparison group was also found no difference in those long distance integrity of white matter over that short 2-year follow-up. So the evidence is a little bit mixed in terms of whether or not there is an accelerated or progressive brain change. But we were very interested in studying this using a large sample, and we decided to use a cross-sectional design, meaning that we compared people with and without bipolar who ranged in age from 30 to 69. We did lots of different assessments, including a whole panel of brain measures like the ones that I was telling you about before. Brain size, looking at the integrity of the long distance tracts, the white matter abnormalities, blood flow at rest, and functional MRI both during task and the coordination at rest. And we have found some evidence for what looks like it could be accelerated white matter aging. So in the right uncinate fasciculus, which is circled down here in red, the tract here is circled in red, or the area that was different. You can see this is a tract that actually connects the medial prefrontal cortex to the amygdala and has been thought to be very important in emotion regulation. And the integrity of this tract is lower in older people with bipolar than it is in younger people with bipolar, as shown by the solid line and the circles. Whereas in the healthy control group, you can see that those are in the dotted line and the triangles, and there, if anything, there's a slight increase in integrity with age, but it's basically flat. So the bipolar group is showing a different pattern of age-related differences here. Similarly, in terms of processing speed on a cognitive task, in terms of how quickly they could respond to stimuli, the older people with bipolar disorder were much slower on the task than the younger people with bipolar, whereas there was not that big of a difference in this age range in our non-bipolar comparison group. So we had some evidence from one of our brain measures and from our cognitive measures of this kind of accelerated pattern, but we wanted to explore that a little bit more using as many of the different brain measures as we could. So we studied in 126 participants, 47 euthymic outpatients, so meaning they were between episodes with bipolar 1, and 79 healthy individuals that were a comparison group, as well as a subset that we matched on age and education to the bipolar group. We studied many different brain measures, and these are some of the same ones that I've gone over before. So we looked at the volume, surface area, and thickness of different brain regions. We looked at the mean blood oxygenation level dependent response in some areas that were responsive to working memory tasks. We looked at the correlations between different regions at rest to understand the coordination of these big networks. We also had the deep and periventricular volume of white matter hyperintensities, as well as the integrity of the long distance tracts using diffusion tensor imaging, and finally resting blood flow. So we had all these different measures, and we said, what if we put all of these together in order to try to predict how old somebody is? So what we did is we threw all these different measures into one big equation to see if we could accurately predict the chronological age of the healthy individuals. And so using this regression, we came up with an equation that if you, say, had 2 times the volume of your hippocampus minus 3.1 times the thickness of your cortex plus 2.1 times the degree of activation during a working memory task, etc., then your actual age was, say, 45. And we tried to get that to predict actual age as closely as possible in the healthy comparison subjects. Then we used that equation and applied it to the brain measures of the people in the bipolar group to see what age was predicted based on their brain. And then we created what we call the brain age discrepancy score. It's the brain age predicted from the brain measures minus your actual age. And so again, going back to that example that I gave before, if you have a 45-year-old with bipolar disorder, but their brain looks like the brain of a 60-year-old healthy individual, then they would have a brain age discrepancy of 15 years because their brain looks 60, but they are only 45. And then we compared that brain age discrepancy between the matched groups of those with and without bipolar, and then within the bipolar group, we wanted to see what kind of features were associated with higher or versus lower brain age discrepancy. So this picture shows how well we were able to actually predict people's chronological age based on the combination of their brain measures in the healthy group. So you can see that we've created a very tight prediction. So most people, basically, if you're on this line, that means that your brain age is exactly the same as your chronological age. So we had some people that were a little bit younger and some people a little older, but it was basically within a year. And so we did a very good job of predicting this within the healthy group. And then we took that equation and applied it to people within the bipolar group. And what we found is that on average, the people in the bipolar group, their brains were about 5 years older than their chronological age. So for example, if the person in the bipolar group was 50, they might have a brain age that looked more like 55. And but you can see that there was also a big range. So some people had 30 years of discrepancy, and some people had the opposite, where their brains looked 20 years younger than their chronological age. So we were very curious about what factors were related to this variability within the bipolar group. And we found that brain age discrepancy was largest among people who were young. So this was kind of surprising to us. So the younger you were, the older your brain looked relative to your actual age. And we think that this might be because the older participants in our study are those that maybe have had a younger brain to begin with, and that's why they've made it this far, and that's why they've been able to be in our study and participate in research and whatnot. So there may be sort of a bias in terms of who comes into our study, whereas the younger individuals, some of them at least have a much older looking brain than they should. We also found a gender difference that that men had a bigger brain age discrepancy. Their brains were on average about 11 years older versus in the women who had brain age discrepancy of only about 3 years. And we also found that people who had a lower premorbid IQ, meaning that their kind of fund of knowledge that is likely to not be affected by the disorder itself, was if that fund of knowledge was lower, then their brain age tended to look older than their chronological age. And then finally, and of interest to this idea of progression, we also found that for a given age, those who had had more manic episodes had a larger brain age discrepancy. Their brains looked older. So a given, say, 40-year-old with bipolar who had had, say, 6 manic episodes versus a 40-year-old who had only had 2 manic episodes in that time, the one with 6 manic episodes might have an older looking brain, suggesting that potentially there is a deleterious effect of those manic episodes on the brain, although we can't rule out the fact that maybe people who have this older looking brain is something that they've had all along, and that's actually what led to them having a more severe course of bipolar and having more manic episodes. So in summary, we found possible accelerated aging for white matter microstructure in this one tract that connects the medial prefrontal to the amygdala. We found that brain age was about 5 years older than actual age, and this compares pretty similarly to studies who've done similar type of analysis in major depression, schizophrenia, traumatic brain injury, but is less than what is seen in terms of brain aging in Alzheimer's disease. And we wonder if our results suggest a possible progression due to manic episodes. So now I want to turn to talking about inflammaging. So as we get older, the body's natural healing process of inflammation tends to kind of get out of whack, and we end up having a pro-inflammatory state. So what I mean by inflammation is if you cut yourself or bang your arm or something like that, as you know, it will get red, it will be tender, swollen, and it will be a little hot to the touch. That is our body's natural initial innate immune response to injury, and then those are sort of the sentinels that then tell immune factors to come and make sure that there's no invaders and no infection that they need to fight. So that inflammatory response is very healthy. But unfortunately, as we get older, it kind of gets unregulated. So instead of being damped down and have the inflammatory signals go away, they sort of stick around in the blood. And unfortunately, that's been related to lots of things that are bad for you, like obesity, oxidative stress, which is like damage that can free radicals that can damage your neurons, damage to the DNA, etc. So this pro-inflammatory process with age is not something that is something that people are very interested in terms of how it might relate to age-related morbidity, mortality, cognitive change. And in fact, we saw in a small study that we did that people, older adults without mental illness who did a working memory task in the fMRI scanner, those who had more of these pro-inflammatory blood-based markers like interleukin-6 and C-reactive protein, the more of those they had in their blood, the worse their activation was in this working memory task. So there definitely are relationships between inflammatory processes and the function and the structure of the brain that we were just talking about. And there's been a lot of interest in bipolar disorder in the role of inflammation and especially how it might be related to progression over time and changes in cognitive impairment over time. So this is an example of one study that's actually looked in the brain at a marker of neuroinflammation, which is this imaging of activated microglia. And they looked in the hippocampus of people, a small sample of people with and without bipolar disorder, and they found significant increases in signs of neuroinflammation in the right hippocampus and a trend in the left hippocampus. This was Harmon et al. In 2014. So we were interested in the role of inflammation and how it might be related to cognitive change over time, as well as to other factors, physical aging over time. And we're currently doing a study that's funded by the National Institute of Mental Health, where we bring people in for a burst visit for 2 weeks in which each year, in which we see them in the lab and then we give them a smartphone to make ratings 3 times a day, as well as an actigraphy watch that measures their sleep and their physical activity. And then we also take their blood 3 times during the 2-week period and do some cognitive testing. And then we repeat that again each year, following people up for up to 4 years in the bipolar group. And we have a range of ages at the beginning of the study so we can examine what the long-term trajectory is in people depending on what age they start the study. And the biosamples, we're looking for these inflammatory markers in the blood. And so we have 3 blood draws, about 15 milliliters over those 2 weeks at 1-week intervals at the same time of day. And we subject these to a sandwich amino assay, which allows us to see levels of things like cytokines and chemokines in the blood. And then we look at both the mean levels of those markers over the 3 weeks, as well as the variability in the levels of markers over the 3 weeks. So if you look at this schematic up in the right-hand corner, the green line shows a marker that's very stable over the 3 blood draws, and it's a mean level of 4 with a very small variability. So that's the intra-individual standard deviation. It's very small. The red line shows a mean of 4, but a much higher variability. So it's the same mean, but there's a lot more change across the 3 weeks in that person. So, so we looked at both the mean and the intra-individual standard deviation. And this preliminary sample, it's an ongoing study, but the preliminary sample was very well matched in their demographics. We did see a difference already in this preliminary sample in terms of their stroke risk factors, which relates back to what I was saying about cardiovascular and cerebrovascular risk in people with bipolar disorder. And then what you can see here from our preliminary results is that there were elevated pro-inflammatory markers, interleukin-6, tumor necrosis factor alpha, C-reactive protein, and 3 different chemokines, MDC, eotaxin-1, and IP-10. All of these are pro-inflammatory compounds that get released and are elevated in aging, but also elevated in bipolar disorder in this sample, in an age-matched sample. We also found in a separate study that most of these were also elevated in a sample of patients with schizophrenia, so this may not be specific just to bipolar disorder. And these graphs just show that slight elevation in these levels of the three markers, inflammatory markers. But we were interested in what correlated with those levels of inflammation within the bipolar group, and we found that people who were more depressed had higher levels of the inflammatory markers IL-6 and CRP. People who had a slightly greater mania severity were also had slightly higher IL-6 levels. And importantly, some things like obesity or body mass index was also related to inflammation. So people who had a higher body mass index had higher levels of C-reactive protein and IL-6, which I'm not showing here. And people with a higher body mass index also had altered variability of the interleukin-6 across the 3-week period. We only saw trends for relationships with age with these markers, but it is a preliminary sample that we're just still collecting. And we also saw that TNF-alpha was higher in those with higher duration of illness, suggesting potential chronicity-related associations there. So this is an ongoing study, and I hope to be able to perhaps come back and do another webinar to talk about all the interesting things that we'll find for this study. But we still really lack full knowledge of the long-term longitudinal trajectory of symptoms, cognition, and brain in individual patients with bipolar disorder and the role of things like inflammation in that. And so we really need to understand why some people may have a more steep trajectory of aging and some people may not, and to therefore determine, are there ways that we can identify who's at risk for accelerated or premature aging, and how can we prevent those declines? What are some of the modifiable risk factors that can help us to slow declines in people that are vulnerable to these? And so this brings me to my final point, which is that I think that it's not too early to say that there are some treatment implications of considering bipolar disorder as a whole body disorder. And that is that many of the things that we know to be helpful in minimizing the impact of age without mental illness can also be helpful in the context of bipolar. So lifestyle interventions, eating right, getting good exercise, stopping smoking, all of these things are good for the body and they're good for the brain, so they're good for bipolar disorder as a whole. Also, to the extent that the more chronic of a course someone has, the more likely they may be to suffer some of these precipitous declines, it's important for us to diagnose and treat symptoms early and to treat symptoms effectively. So as much as people can find and maintain, in collaboration with their treatment providers, find and maintain a regimen that minimizes the number of manic episodes, this could potentially help to stave off some of this premature aging. And I can't emphasize enough how important it is for us to take a whole body integrative approach. I think for too long in bipolar disorder, we've had sort of the psychiatrists and psychologists treating people from the neck up, and then primary care physicians and internists treating people from the neck down. And it's really important that we treat the whole person, that there is a coordination of care between different providers, and that people understand that this disorder is looking like it actually has implications for the entire body, and that what happens in the body affects the brain and vice versa. And so this kind of integrative approach is very important. And people are working on whether the role for inflammation, working on the possibility of having anti-inflammatory pharmacological treatments that might be helpful, but also many of the things that we do to change our lifestyle, like eating better, exercising more, have anti-inflammatory benefits to them. And so there's things that we can do right now before the research gets there in terms of pharmacology to start doing things to help us regulate the inflammatory process, which may be contributing to some of these declines. So I'd like to just acknowledge all of the people who've collaborated with me on these studies, the mentees that I've worked with, the staff, the funding agencies that help make this possible, and of course all the wonderful participants that give so generously of their time. And if you happen to be in the San Diego area and would like to participate in our ongoing study, or if you have a loved one that would be interested in participating, please contact me, because we are still doing this study and we would love to have more participation. So with that, I will thank you for your attention, thank the foundation for their support and for asking me to come here today, and see if there's any questions that anybody has.
Yes, thank you, Dr. Eyler, for sharing your expertise. So we have a couple questions coming in. First of which is, what is the best source to follow you and your research?
Well, I do have a website, so you can take a look at my website. It's bipolar-aging.com, so you can take a look at that website, and then of course we regularly publish in the journals and that sort of thing. And if you are a participant in our study, we try to put out newsletters every once in a while to say how things are going. But probably the website is the best way to reach us.
Okay, great. Thank you for that. Another question is, can you have your inflammation markers measured at your doctor's office?
So you definitely can. I think the difficulty is that what we don't really know yet is there's lots of things that affect your level of inflammation, like if you have allergies, or if you have a cold, or if you have some sort of an infection. And so what's difficult to know right now is if you were to get it measured on a particular day and you had an elevation in something, how meaningful is that? So one of the things we're trying to figure out through this study is, what are meaningful levels of elevation? How quickly do they change from week to week? And also, what's the chicken and the egg? So because we're measuring 3 times within this 2-week period, some analyses that we want to do is to see, does mood change and then inflammation results, or is it that inflammation goes up and then mood changes? So we're trying to figure out more about this biomarker so that it can be more clinically useful. But right now it's difficult. Any one blood draw and any one level may not tell us very much.
All right, thank you for that. Let's see. Do we have an idea or a theory of what could be causing the cortical thinning in bipolar disorder?
So there are definitely lots of theories about it. The role of oxidative stress is something that people are looking into a lot. So the types of for example, the inflammatory dysregulation may lead to an overabundance of free radicals, which then can have a sort of toxic effect on the neurons. And so that may be a factor. Interestingly, I didn't mention, but one of the things we're looking at very carefully is the role of medications, including lithium, because some studies have shown that lithium can actually have a neuroprotective effect, that it seems to decrease this cortical thinning that you see. So people are still working on trying to understand the exact biological mechanisms, but my guess is that inflammation, oxidative stress, and then a potential protective role of lithium are all going to be very important factors.
Very interesting. The next question is, I have read that meditation and exercise can increase the hippocampus size. What is your response?
I totally agree. I think that we, I think one of the things that we have to be careful about, and I always say when I'm talking to audiences, and I may have failed to mention it today, is that I talk a lot about potential brain changes and alterations in the brain, and sometimes that gets people kind of depressed, thinking, oh my gosh, my hippocampus is smaller and my cortex is thinner. What hope is there? But the exciting thing is the brain is very plastic, and we're learning more and more about how the brain, even in adulthood, can change based on our behaviors. And so some of the things that we're showing that the literature is showing is that yes, indeed, you can do things like increase your hippocampal size, increase your cortical thickness from exercise, from meditation, from these lifestyle changes. So that none of this, as far as we can tell, is irreversible. And so I think that's positive and very hopeful news, in that if we can find the right combination for you of lifestyle changes, that's something you can stick with and that you can do, you may be able to combat these changes, that they're not, it's not irreversible.
Yes, that's great news to hear, for sure. So just a reminder to everyone, while you're typing your questions, that this webinar is being recorded and will be archived on our website for future reference. We'll wait a minute or so to see if we get any more questions in. All right, Dr. Eyler, do you have any other last pieces of information you want to share, or anything else you want to address?
No, it's been my pleasure to speak with you all today, and I hope that you will get in touch with us through our website, or you can email me directly at lteyler@ucsd.edu if you have any follow-up questions, or if you're interested in, if you're local and you're interested in participating in our research or getting resources, I'd be happy to do that. And again, just emphasize that the more we think of bipolar as a whole body condition, that we need to, start treating from the earliest ages, and also thinking about how we can just improve our wellness overall, I think the better off we'll be.
Absolutely. Well, thank you very much, Dr. Eyler, for sharing your expertise with us today, and we hope to see you all at our next webinar. Thank you.